Okay. Over the past 3 weeks, over the past 3 weeks, okay, I need the pen to,
You need the pen too.
I don't know, this is not highlightable. Okay, now, over the past 3 weeks, a 64-year-old right-handed man has 5 episodes of blindness of eye, blindness of left eye lasting 12 to 20 minutes. His history is otherwise non-contributory. Which of the following is the most
Mhm.
appropriate next step in the diagnosis?
Ready?
Yes.
Okay, so it's carotid Doppler scan. Morosis fugae refers to transient vision loss lasting from several to minutes, typically caused by ischemia of the retina or optic nerve. Vision loss is typically unilateral, but occasionally bilateral. Most common cause is ipsilateral carotid artery disease with emboli to the retinal or optic nerve vasculature. Although amaurosis fugae may also occur in the setting of vasculitis like temporal arteritis. Amaurosis fugae is a medical emergency because it may herald either impending stroke due to carotid embolization or impending irreversible vision loss due to either embolization or vasculitis. Evaluation should include immediate carotid Doppler scan to evaluate for carotid vascular disease. Patients with symptoms suggested of temporal arteritis such as fever, chill, weight loss, headache, chalk indication should undergo immediate lab evaluation of platelets and systemic inflammatory markers and should be considered for immediate high-dose steroid therapy. Ophthalmic exam may show retinal vascular emboli, known as Hollen's-Ford plaques, although most patients with amaurosis fugax will have a normal ocular exam. Next.
A 77-year-old man is brought to the emergency department because of 2-day history of headache and confusion and blurred vision. He has not he has not had any recent trauma to the head or eyes. He has chronic hypertension, type 2 diabetes mellitus, irritable bowel syndrome, bilateral hearing loss, bilateral hearing loss. Current medications are hydrochlorothiazide and glipizide, amlodipine, losart, and chlordiazepoxide. On arrival, he is holding his head in his hands. He is oriented to name and place. He is oriented to name and place, but no, not to date of birth, month, year, or the current president. His temperature is 37 degrees Celsius, pulse is 64 per minute, respiration 12 per minute. Blood.
Omar, I have to answer this. You
Yes,
give
yes.
me 2 seconds. 2 seconds.
Okay, I'm reading the question again.
Okay.
A 77-year-old man is brought to the emergency department because of 2-day history of headache, confusion, and blurred vision. He has not had any recent trauma to the head or eyes. He has chronic hypertension, type 2 diabetes mellitus, irritable bowel syndrome, and bilateral hearing loss. Current medication are hydrochlorothiazide, glipizide, amlodipine, losart, and chlordiazepoxide. On arrival, he is holding his head in his hands. He is oriented to name and place, but not to date of birth, month, year, and current patient. His temperature is 37 degrees Celsius, pulse 64 per minute, respiration 12 per minute, blood pressure 230 by 130 millimeter of mercury. Visual acuity is 20 by 30 in both eyes. A visual field are equal. Fundoscopy examination show blurred optic disc margin and several slit-like hemorrhages in the both fundi. CT scan of the head show hypoattenuated area in both occipital lobes and old lacunar infarct in the basal ganglia and thalami. Which of the following is the most appropriate initial pharmacotherapy?
Ready?
Yes.
So it's IV labetal or hypertensive encephalopathy results from acute or severe increase in BP, potentially manifest headache, vomiting, agitation, altered mental status, seizure, may progress to coma. Visual symptoms may result from cortical dysfunction or from hypertensive retinopathy, including retinal hemorrhage and exudate. Treatment includes careful lowering the BP, general IV agents such as labetalol, esmolol, or nicardipine, and etoposide I prefer for initial management. It's not, what was I? C. IV dexamethasone is often used in spinal cord compression or cerebral edema, secondary to brain tumors. Steroids are part of the management of hypertensive, are not part of the management of hypertensive encephalopathy. You wanted me to read another one?
No.
Okay, next.
A 57-year-old man is brought to the emergency department he had after he was found walking unsteadily and speaking in a confused and incoherent manner. Neurologic examination shows bilateral abducens nerve pulses, coarse nystagmus in all directions of gaze, and severe truncal ataxia. Which of the following is the most likely diagnosis? Confused. Coarse nystagmus.
Ready?
Six nerve pulse. Wait 1 second. Truncal. Okay.
It's Wernicke. Vitamin B1 thiamine plays a complex role in neuronal physiology, including axon conduction, glucose utilization, um, axon conduction, glucose and neurotransmitter synthesis. Thiamine deficiency results in neuronal damage to a mechanism that likely involves oxidative toxicity. Thiamine deficiency causes two potential syndrome, Wernicke and Korsakoff. Classic triad of Wernicke encephalopathy, ataxia, oculomotor dysfunction, um, due to neuronal damage of cerebellum, midbrain, and pons. Common ocular manifestation is nystagmus, horizontal gaze palsy as a result of damage of the adenosine. Thiamine deficiency is most encountered in the setting of alcohol use disorder or due to poor any whatever. Over time, thiamine deficiency can result in damage and atrophy of mammillary body, visible on MRI of the brain, which manifests as Wernicke encephalopathies. Um, Symptoms of Wernicke are reversible but increase the risk of developing Korsakoff in chronic alcohol users if not treated with high dose thiamine. Wernicke-Korsakoff syndrome is an irreversible condition that features psychosis, anterogenital amnesia, and consequent tendency to confabulate. It is not lead poisoning, presents with cognitive dysfunction, encephalopathy, hearing loss, and peripheral neuropathy. Distal motor neuropathy causes low motor neuron sign, including weakness, atrophy, hypotonia, hyporeflexia. Non-neurologic manifestation of lead poisoning, including tubular dysfunction, vomiting, abdominal pain, constipation, anemia. And it's not E. Oh, sorry. I'm going to the. Okay, this one doesn't show all the answer choices. Okay, next. Next.
Yes. A 24-year-old man comes to the physician 1 week after he had a generalized tonic-clonic seizure at work. His symptoms begin his symptoms begin with a rising sensation. His symptoms begin with a rising sensation in the upper middle abdomen. His coworker told him that he started to stare, licked his lips, and then fell to the floor. He has generalized shaking of his arms and the legs. After he awakened, he was confused and several minutes and smelled an odor of burnt rubber. His coworkers did not notice. He has a similar odor 3 times in the past 2 months. He was hit by a baseball bat at the age of 12 years and had a brief loss of consciousness. He has been otherwise healthy. Physical and neurological examination shows no abnormality. Which of the following is most likely a location of this patient's abnormality?
Next. Ready?
Sorry.
Ready?
Yes.
With temporal lobe, focal onset impaired awareness. Seizures are also called complex partial seizures. As this name suggests, these
We have
seizures
found
affect.
another question previously where
Mhm.
complex seizure happened in the temporal lobe.
Mhm. These seizures affect a specific focal region of the brain and, and therefore produce motor or sensory symptoms that are localized to one or a few affect areas of the body. Patients will be um, unresponsive during the seizure. Focal seizures can spread to bilateral hemisphere involving the to generalized tonic-clonic seizure. As this patient, tonic-clonic seizure are characterized by the sudden onset of muscle contractions followed by rhythmic jerking of all extremities, oral automatisms, and autonomic disturbances such as a pregastric rising sensation at this patient are suggestive of temporal lobe lesion, the most common origin. Manual automatisms and upper limb dystonia can also occur in temporal lobe seizure. Patient may experience visual, auditory, or sensory auras preceding the seizure. Okay, focal onset impaired awareness seizure are often accompanied by pre-post-ictal state marked by confusion and fatigue. This seizure will demonstrate localized rhythmic activity with generalized slowing on EEG. They may require antiepileptic medication for patients with refractory temporal lobe epilepsy. Surgical excision of the lesion can be done. It's not frontal lobe lesion. Lesions can also present with focal seizure with impaired awareness. Disturbances of the higher cognitive functions of the frontal lobe can lead to features such as speech disturbance, complex automatism, and strong emotional expression such as crying or laughing. Focal seizures with intact awareness with motor symptoms may also occur as a result of the involvement of the primary motor cortex. Focal seizure with intact awareness and motor symptoms. It's not parietal lobe lesions can lead to, let me read it here. Parietal lobe lesions can result in focal seizure activity involving the primary somatosensory cortex, resulting in sensory disturbance such as numbness, tingling, warmth, and pain. Other manifestations of parietal lobe epilepsy may include receptive aphasia, dyslexia, and other language comprehension disturbances due to involvement of Wernicke area and the junction of the parietal and the temporal lobe. Okay, next.
A 67-year-old man has had 4 episodes of aphasia over the past year. His temperature is 37 degrees Celsius, pulse 84 per minute, respiration 12 per minute, blood pressure 142 by 82, serum glucose is 150, cholesterol is 296, HDL concentration 20, carotid ultrasonography showed 90% stenosis of the left internal carotid artery. Which of the following is the most appropriate therapy to decrease the patient's risk of stroke?
There is cholesterol. There's 96, HDL 28.
Ready?
One moment. Yes, ready. So it's carotid endarterectomy. Patients with 4 separate episodes of acute aphasia that self-resolve as a presentation concerning with multiple TIAs. TIA is defined as transient episode of neurologic function caused by focal brain spinal cord retinal ischemia without evidence of infarction. The system lasts less than 24 hours and may take as little as a few minutes. Patients with TIA are increased risk for having ischemic stroke. Therefore, management of patients with TIA should focus on identification and treatment of modified risk factors. Such risk factors include large vessel atherosclerosis, arrhythmia, non-cardiac thrombus, smoking, hypertension, hyperlipidemia, alcoholic state. Patients who have been diagnosed with TIA should undergo MRI, Doppler ultrasound of the carotid artery, echo, cardiac monitoring. Patients with 70 to 99 stenosis of the carotid artery should undergo carotid endarterectomy or carotid stenting to decrease their subsequent risk of stroke. It is not, this one don't have really high blood pressure. Um, Control of BP and control of LDL concentration with diet modification and medication, and control of serum glucose concentration with diet and whatever are important measures that should be taken to decrease the risk of stroke in patients. Aspirin therapy is also indicated as secondary stroke prevention in this patient. However, carotid endarterectomy should take precedence for this patient with non-significant carotid atherosclerosis, as this was likely the direct embolic source of this ischemic event and will lead to, yeah, this reduction in all that. It's not, yeah, I think that's it.
Okay, next. A 60-year-old woman is brought to the office by her husband because of 6 week history of progressive unsteadiness in coordination slur speech. During the past 6 months, she also has non-productive cough, fatigue, 7 kg unintentional weight loss, Despite no changes in appetite, she has not seen physician in more than 10 years. She has not been a physician for more than 10 years and does not take any medication. He smoked up. He smoked. He has. She has smoked 15 cigarettes daily for the past 40 years. She drinks alcoholic beverage only on social occasions. Temperature is intact except for bilateral horizontal nystagmus. She has no focal muscle weakness or no sensory deficit. Finger nose testing and heel shin testing discloses bilateral dysmetria, deep enhancement of the cerebellar folia. MR angiography of the circle of the Willis show no abnormality. Carotid Doppler ultrasonography discloses minimal stenosis. Is the common carotid arteries bilateral? Which of the following is the most likely cause of these patient's symptoms? Dizzy.
Ready?
1 minute.
Okay.
Okay.
Okay, so it's paraneoplastic syndrome. A variety of paraneoplastic neurologic syndromes may occur following abnormal immune response to the presence of underlying malignancy. The most implicated tumors are small cell lung cancer, breast ovarian cancer, Hodgkin lymphoma. In many cases, the onset of paraneoplastic disorder may precede detection of the primary malignancy. Therefore, patients may present without a non-cancer history and high index for an occult tumor must be maintained. Paraneoplastic cerebellar degeneration is a break disorder characterized by the function of the cerebellar vermis with signs and symptoms of ataxia, intention, tremor, vertigo, nystagmus, dysarthria, eventual loss of ambulation. A variety of antibodies may be detected in association with PCD, paraneoplastic cerebellar disease. Most common anti-U antibodies, which target an antigen specific to cerebellar Purkinje cells. MRI often shows cerebellar atrophy. Further diagnostic events should be performed to identify the primary malignancy in patients with PCT. It's not Miller-Fisher syndrome, it's a subset of Guillain-Barré syndrome, autoimmune demyelinating disorder. Miller-Fisher's characterized by triad of ophthalmoplegia, ataxia, and areflexia. This contrasts with Guillain-Barré, which presents with acute onset ascending bilateral muscle weakness. This patient has normal deep tendon reflexes, suggesting against diagnosis. Multisystem atrophy is a Parkinsonian neurodegenerative disorder characterized by Parkinson, autonomic dysfunction, and ataxia. Autonomic symptoms may include orthostatic hypotension, dry mouth, anhidrosis, urinary retention, electric dysfunction. Yeah, and it's not progressive supranuclear palsy. It's Parkinson uh, plus gait instability, oculomotor deficit like vertical gaze palsy, frontal lobe deficit, bradykinesia, and muscle rigidity.
So, how you diagnosed this as paraneoplastic syndrome?
Mm, I guess, but I just she has she has some kind of cancer because she's losing weight, she's smoking, whatever. So it's cancer. So I
Okay.
just yeah, I just went from that. I just didn't remember what was I knew it wasn't progressive because we had a question yesterday, and I knew that progressive comes with
Progressive supranuclear palsy comes with
you know,
vertical gauge pulse.
but either way, it comes with something with Parkinson. But
Yes,
in there is
yes.
nothing Parkinson here, and I didn't know what the other two were, the Miller and the I didn't know what the other
Miller
two.
Fisher is one sort of uh, Guillain-Barré.
Yeah. And then I knew for sure it wasn't cruise something because
Creutzfeldt-Jakob is rapidly progressing
yeah.
myoclonus dementia.
So that was, and I didn't remember what the multi system was. So I just went with paraneoplastic because I know she has some kind of cancer for sure.
Okay, A7 of a previously healthy 16-day old male newborn is brought to the emergency department by his parents because of 6-hour history of temperature 13.8.9 degrees Celsius, 102 Fahrenheit, fuzziness, and decreased feeding. He was born he was born at 39 weeks of gestation. 32-year-old woman, gravida 2, para 2, weight 3 kg. The mother received routine prenatal care. The pregnancy was uncomplicated by group B streptococcal infection. 37 weeks of gestation. No other abnormalities were noted on screening. The mother received 3 doses of intrapartum penicillin. The patient was discharged on the second day of life. Well, child examination on days 3 to 14 of life showed no abnormality. At 2 weeks of age, he weighed 3.2 kg. He is currently breastfeeding. He has not had sick contacts. Today he weighs 3.2 kg. Its circumference is at 50 percentile. His rectal temperature is 38.8 degrees Celsius, 101.8 degree Fahrenheit, pulse 142 per minute, regular respiration 48 per minute, blood pressure is 58 by 40. Examination shows no cyanosis or rash. The head is normocephalic with no signs of trauma. The anterior and the posterior frontanelles are open and below table. The anterior fontanelle is not bulging. There is a mild scleral icterus. The liver ridge is palpated 1.5 centimeter below the right costal margin. The spleen is not palpable. The umbilical cord has detached. The umbilical cord has detached. The site is dry and non-erythematous. A lumbar puncture is performed. Results of an urinalysis, blood, and CSF are pending. Which of the following is the most appropriate next step in the management?
Ready?
Yes.
So it's IV, ampicillin, and gentamicin. Neonatal sepsis is often categorized in the basis of time frame from parturition, as the period of time in which symptoms begin may indicate which pathogen is likely involved. Thereby guiding early onset neonatal sepsis occurs within 3 days of birth, generally as a result of exposure to pathogen acquired from a mom, either through hematogenous or transplacental spread, or commonly contact in acquisition with the birth canal. Late onset neonatal sepsis presents soon 3 days or more after birth. It is most likely acquired by contact with environmental pathogen, although those acquired from the mother are still possible. Neonatal sepsis often present with symptoms of lethargy, fever, poor feeding with cry, respiratory distress. The most common pathogen associated with late onset neonatal sepsis is group B strep and E. coli. Infants admitted to the NICU are also at risk for other gram-negative bacteria. coagulase negative staph, and Staph aureus. Syndromes of serious bacterial infection include bacteremia, meningitis, pneumonia. Workup for suspected case of sepsis in a child younger than 30 days. Of age may include blood cultures, lumbar puncture, chest X-ray, CBC, or analysis, depending on the timing and all. Treatment includes IV broad-spectrum antibiotics most common to cover the common pathogen. The combination of ampicillin and chamycin is preferred due to effective coverage against the most common causative agent of neonatal sepsis. It is not IM intramuscular ampicillin gentamicin could be an appropriate choice if the newborn requires only one dose of antibiotics. This patient will require several days of antibiotics, and therefore IV administration is more appropriate as it avoids the need to restrict the newborn multiple times. Okay.
Okay, next.
Mhm.
An 18-year-old an 18-year-old man comes to the office because of 3-month history of increasingly severe knee pain. The pain was originally mild and intermittent, but has progressed to severe and constant. She has noticed fullness she has noticed a fullness in the area above the knee during the past month. During the past 2 weeks, there has been increased difficulty walking and bearing weight on the affected leg. There is no recent history of trauma. She ha- he says that he has not been feeling well overall. During the past month, he has had 2 kg unintentional weight loss and decreased appetite. He has no other history of serious illness. His only medication is ibuprofen as needed for partial pain relief. Temperature is 37 degrees Celsius, pulse 85 per minute, respiration 12 per minute, blood pressure 135 by 80. Physical examination shows erythema and tenderness of the left distal thigh above the knees. There is limited flexion of the knee, X-ray of the knee of an area, medullary and cortical bone destruction and periosteal new bone formation in the diaphyseal end of the lesion. Which of the following is the most appropriate next step in the management of the underlying condition?
Ready?
Yes.
There is operative treatment of the knee and chemo. Osteosarcoma is a rare primary malignant tumor of the bone that affects the metaphysis of long bones. Osteosarcoma has bimodal distribution, most frequently affecting adolescents and patients over 60 years old. Presenting symptoms include localized pain, pathologic fractures at the areas of involvement, and associated weight loss. Physical exam may show a large, tender, palpable soft tissue mass. Imaging, including X-ray, MRI, may be used to evaluate the extent of involvement. Standard of care for otherwise healthy patients with osteosarcoma include surgery and chemo. Okay.
Next,
Mhm.
a 67-year-old man with a 15-year history of emphysema comes to the office because of right-sided shoulder pain. For 6 months. He has not had chest pain, palpitation, headache. He has smoked two packs of cigarettes daily for 40 years. He has worked as a coal miner for 45 years. He appears older than his he appears older than his age. He is not in distress. His temperature is 37 degrees Celsius. Pulse is 100 per minute, respiration 20 per minute, and blood pressure is 120 by 80 millimeter of mercury. Pulse oximetry on the room air shows oxygen saturation 92%, left pupil is 3 millimeter, right is 2. They both react to the light. There is ptosis on the right. Examination showed decreased diaphragmatic excursion on the right and prolonged expiratory phases. There is a moderate clubbing of the fingers. Intrinsic muscles of the right hand are atrophic. Muscle strength 4 by 5 in the upper extremity. X-ray of the chest shows 3 to 4 centimeter right, 3 to 4 centimeter right apical mass. Which of the following is the most likely mechanism of this patient's shoulder pain?
Positionalisis, spinal cord, infiltration of brachial plexus, malignant cell. Okay, ready?
Yes.
So, what was that one? Is infiltration of the brachial plexus with malignant cells. Bronchogenic carcinoma commonly presents with cough, weight loss, hemoptysis, and potential signs of bronchial obstruction, such as wheezing, prolonged expiratory phase. If the carcinoma is located within the lung apex, referred to as pancreas, it can infiltrate multiple adjacent structures such as the superior vena cava, subclavian vessels, and sympathetic chain, recurrent um, laryngeal nerve, and brachial plexus. This can result in presenting features of Horner syndrome, unilateral ptosis, meiosis, and idosis, ipsilateral shoulder and upper extremity pain, and hoarseness. If the pancreas involves the right lung apex, superior vena cava syndrome may occur, which manifests with bilateral upper extremity facial swelling, erythema, and vascular congestion caused by insufficient venous drainage from the mass effect of basal invasion. Pancreas typically presents as a consolidative rounded mass on the apex lung on chest X-ray and CT scan. Extrinsic compression of the spinal cord can occur with metastatic cancer to the spine or with an infection such as epidural ulcer, which can present with weakness and numbness in a dermatomal or myotomal distribution. Yeah, it will be unlikely to cause Horner syndrome. Got it. Next.
Okay. A 72-year-old man is brought to the physician because of 1 year history of progressive difficulty in walking and 2 month history of urinary incontinence. His wife reports that he is extremely slow to answer questions. Neurologic examination shows bilateral grasp reflex and increased muscle tone in all extremities. When he tries to walk, he appears glued to the floor and cannot take steps without assistance. He is oriented to person, place, and time, but speaks very little. Which of the following is most likely increased in this patient? Ready?
One moment. Ready.
Okay.
Medical aside, this patient presents with findings suggesting of NPH, normal pressure hydrocephalus, with a characteristic combination in dementia, gait, instability, and urinary incontinence. NPH refers to a type of communicating hydrocephalus in which the ventricles are enlarged, leading to damage of the white matter tract connecting the frontal lobes and basal ganglia. Patients commonly present with frontal cognitive deficit, frontal release signs such as the emergence of the grass reflex, and subcortical cognitive deficit like psychomotor slowing, inattention, executive dysfunction. Signs of increased intracranial pressure like papilledema, postural headaches are typically absent. Um, Many cases of NPH are idiopathic, though some are secondary to defect in CSF drainage from the ventricles due to scarring or obstruction of the ventricular lining from prior hemorrhage or meningitis. The diagnosis is primary clinical, although ventriculomegaly on brain imaging is suggestive. The most appropriate next step in management is lumbar puncture to assess the opening pressure and clinical response to removing CSF. Placement of a ventricular shunt may be needed for long-term management. It's not B. CSF fluid pressure is likely to be normal in this patient as denoted by the name normal pressure hydrocephalus. Excess CSF fluid collects in the ventricle but does not increase the opening pressure. Hmm, okay.
Okay. Can we stop here?
Yeah, we can.
Okay. See you tomorrow.